So our special lecturer for this morning is a colleague of mine that I have spent the last 17 years working with. I'd like to welcome Dr. Baris Turkbey to the stage to speak on will AI and emerging imaging modalities put an end to outfield recurrence. Welcome, Dr. Turkbey.
He's not coming.
What? Hey, God, it's just you.
No video. What would happen?
I don't know. Oh, the other talk, Arjun is not here, so I just canceled. They moved on.
I wasn't expecting, I was going to have a bathroom break, but that's okay. Well, good morning, everyone, and it's a big honor for me to be here, and thanks for inviting me. So I'm a radiologist. Sometimes they call me physician scientist. My focus is trying to make MRI better. And then also we develop AI models in our clinic. And also we utilize molecular imaging. So today I will talk about how we can fix the problems that was very well outlined using computer vision. So these are my disclosures. Okay, so as outlined very well, we have an inconsistency when we do the MRIs and when we read the MRIs and when they are used for biopsies. So that's a big problem, and it's a good problem for something like computer vision or AI. All right, so this paper was published in 2020, and it brings the top 26 academic institutions from North America and Europe. And as you can see, we have a big problem here. So this red line is showing us the 50% cancer detection rate cutoff, and more than half of these centers are doing, are giving you results with yield of less than 50% in terms of cancer detection rates for both prostate cancer and clinically significant prostate cancer. So if this is the picture in academic centers, you can imagine what's happening in the community level. Well, in addition to that, the inconsistency also persists when we show lesions or images to radiologists and ask them to, can you point out where is the lesion and can you delineate the lesion for us? And we do funny things over there. As you see, 6 different readers marked everything in a different fashion. So there are several layers of inconsistency. So the question is, can a fully automated AI model solve this problem? Well, theoretically, it is a yes, but let's see. So to tackle this problem in 2017-18 timeframe, with a urologist, Tom Sanford, we started to work on this problem. And another urologist, Sheriff Mihralivan, published this very nice paper. So it's a very busy slide, but overall what you need to know is about 1,400 patients. I delineated them manually, and then we utilize this to train the AI model. And the results are quite promising. As you can see, the cancer detection rate in a fully automated fashion is about 63%, more than 50%, cut line that you see. And the false positive rate is one lesion in every other patient. An AI model can give you like 20 lesions. You can biopsy all of them and you can, perfect diagnose the patient, but that's not what we want to see. We want to minimize the penalty, okay? Now, we tested out this model in a different patient population, in our biopsy population. This time, it's more than 600 patients, totally unseen population. And it's a diverse patient population, 1/3 being biopsy naive. And these are the results. So the sensitivity and the positive predictive value of the AI model in this unseen population is quite promising. And it is, false positive rate is again 1 in every other patient. And as you see, the cancer detection rate capability is quite similar to what radiologists can achieve. And the radiologist is me, by the way, in this case. So the success is higher, obviously, in higher Gleason grade, patients. So these are some samples. So this is an MRI. I read this prospectively totally negative. Dr. Pinto did a biopsy, and there was a lesion on the left. There was a cancer finding on the left side, GG2, and the AI model delineated this lesion very successfully. I failed in this case. AI beat me. This is another patient. There's the other side of the story always. So I read this lesion over here as like PIRADS 3. And then Dr. Pinto did the biopsy. It was Gleason grade 2. AI couldn't find the lesion. So there are both wins and loses in case of AI. So a little bit pause on our results. So this is the routine story of an AI, application. So you find some data, you curate it, you process it, you build your model test, and then you publish it. So up to this level, everybody is doing that in the literature. You are seeing papers every day. About 10 of them is getting out in radiology especially. But in NCI, what we do is a little bit different. We come to the publication level, but then we go into the deployment phase, which means that we make the AI model alive in our hospital environment for future use. It can be research or clinical, depending on the permission that you may get. And we call this as translational AI practice. If an AI practice is not translational, it doesn't have that much value, unfortunately, nowadays. So please look for that when you are dealing with AI. So what I mean by translation of the AI model, so it is now ready to use in PACS. It took about 2 years to get to this stage. It's the government system, lots of firewalls, etc. But we beat all of them, and this is what's happening in NCI today in the practice. So the user goes into the PACS, chooses 3 imaging modalities, 3 sequences, T2, diffusion, high beam, no injection, and then just pushes this button over here, the OK button. And when this happens, the images are pushed to the model, virtually of course, and the model starts to work. It has like 6 different AI models inside. So it locates which sequence is what, and then it finds the T2, it segments out the organ, and then using that segmentation, it searches all the 3 pulse sequences for cancer signature, it locates the lesion, it delineates the lesion, it gives a PIRADS score to the lesion, and if the lesion has BPH features, there's a BPH filter, it just cancels out the lesion. So the end product is like something like that, something like you see on the right side. So the user waits about 1 minute and 20 seconds, not more than that. And then the images are pushed into PACS. We have binary and prediction maps. And in this particular case, it was a 57-year-old African-American patient. PSA was around 5. I read this negative. The tool gave this large lesion on the right side. And then Dr. Guram, Dr. Pinto biopsied. This was a Gleason 3+5 lesion. Okay? So this is the QR code. Our models are open source. You can utilize this in your hospital in research fashion. And as of May 21st, 2024, that day is important for me, Dr. Pinto, Dr. Guram are using this model to guide their biopsies prospectively. And we observed that the cancer detection rate in a prospective fashion is about 80% in NCI population, and the yield between me and the AI is about 10% gain for AI. This is impressive. We also use this model in guiding radiotherapies. Art mentioned there's a failure. Well, good contour causes less failure, as we all know. We use it for processing our prostatectomy specimens, and we will be using this for focal therapy soon. The model is currently available in these places in the world. We're going to work with European Union colleagues on something called federated learning, and then we will further develop this model. We'll put some more diversity over there, and we will deploy it in low resource setting centers in Africa, hopefully, in 2 years' time frame. All right, that was the lesion detection part, but everything starts with a good MRI, good quality MRI. So this is imaging from our hospital about 6 years ago, and as you can see, there's huge rectal gas, prostate is there, but if you look at the diffusion, almost 70% of the peripheral zone is gone. 70% of the tumors are there, you know it better than I do, and then it means that there's no data, you are blind. It's like driving a car without a seatbelt or taking a flight without a seatbelt. Don't do that to your patients. If you see this, ask for a new MRI, okay? And monitor the quality. Well, it's impossible for us to look at the quality for every image. I do that in our clinic. My office is next to the MRI suite, but we need some help from computer vision as well. So we built an AI model to tackle this problem. It works on T2-weighted images, and I'll walk you through that in a second. This image looks good to me, but, you know, I mean, there's no major signal problem. I can distinguish the structures. But when we feed this model into the AI, when we feed this image into the AI model we built, it says that this is a terrible MRI. It's non-diagnostic. Well, explainability is important in AI. Why this decision was made by the computer. So if you look at this heat map, the brighter yellow areas are associated with the coal. And here is the brightest, and if you look at that carefully, there is some motion over there. And every AI model at this standard should be 3D, and this AI model is 3D, and if you reconstruct this T2-weighted image, these hot areas correspond to that step ladder artifact, you know, which is related with the motion in Z direction. The patient moved, you know, like the patient's prostate moved back and forth when the image was acquired. That's why, you know, this image was labeled as non-diagnostic. Normally, it should be straight like that. So AI was able to catch this out, but I don't know how many times this problem occurs, but it's a big problem, and I will show in the next slide why. So this image is bottom line, not ideal for use to guide your biopsies or to stage your patient's disease. So we tested out this model in an unseen population, and this is our prospective biopsy population, more than 600 patients. All you need to know is this. So if the AI-related quality evaluation tells you that your MRI is bad quality, in PIRATES 4 lesions, you have a significant, almost like 20% performance decrease. So this is related with that registration error due to the motion, very likely. So this is a case in which we failed to find his cancer, and as you can, as you can see, like there is this, you know, this motion artifact over there in the bottom one. There is this stepladder artifact, okay? So quality is critical. Now, I showed you a very good work in AI model. It detects the lesion. So how does this model behave in estimating the tumor burden? Well, this is an unpublished data. You are welcome to take pictures, but if you become a reviewer of this, please remember me, okay? So, it is very difficult to find out, you know, like good quality data for research purposes, especially for this type of a high-risk, high-benefit research. So it includes 108 patients, and the inclusion criteria is having MRI, having pathology slides digitized, and these slides should be delineated by the pathologist. So the pathologist went there on digital scans in a large computer screen. She delineated everything for us. Then what happened is we took the images and the delineations by utilizing an open source code, no human interaction. We registered these pathology slides to our MRIs. And as you may know, we build these customized molds, which allows us perfect registration. So we utilize that technology. And then these are some results. So what we did is we took the routine threshold for cancer detection, which is 55%. We took a more liberal, which is like 65%, and we took a more stringent, which is like 45% thresholds. And then we compared that. Also, in addition to that, they took my prospective contours, which I did before the biopsies of these patients, and then we looked into how well these match with the whole mount pathology. And as you can see here, the least amount of difference is between, you know, whole mount tumor burden versus radiologist tumor burden. AI failed to estimate the tumor burden in this patient population. And this is showing how we did the correlation. Panel B is what I showed you, like the routine AI. Panel A is liberal. Panel C is stringent. D is what I draw. E is what pathologists draw, registered on the MRI. And as you can see, I have like some close performance in a prospective fashion. By the way, this is not a research drawing to the pathologist, you know. And then here, the close look into that indicated that AI couldn't predict in any, you know, PIRATS category, you know, the pathology tumor burden. However, radiologists did well in all PIRATS categories except for PIRATS 5. So still, I don't have a good, you know, like answer how we will, you know, estimate the tumor burden. But if you have a, you know, radiologist which dedicated 17 years of his or her life, you know, to put prostate imaging, you may get success. It is actually not a good result. We were expecting better from the AI in this case. Okay, so this is the summary slide. Successful focal therapy, and I'm looking into this through a, you know, like radiologist perspective, but I spend most of my time with urologists, IR people, and engineers and pathologists. So you need to get a good image quality. You need to, you know, find the lesions, detect the lesions properly, in which AI has a promise in that one. And you need to get consistent PIRATS scoring. PIRATS 2 is not a negative MRI. PIRATS 3 is also a not negative MRI, and you need to further interrogate these lesions if needed, and you need to have a tailored approach. You need to have a good targeted biopsy. I see that lots of registration errors, etc. Still, it is very human dependent and prone to errors. And you need to have a good burden estimation. Unfortunately, AI doesn't help. PSMA also doesn't help because we see lots of mismatches, and it's not predictable whether this is associated with Gleason grading or some other factors. And also you need a good focal therapy method, which requires some real-time feedback. So if all of these things come together, then, you know, you may have a good working system for focal therapy, but more important is you need a strong and collaborating team, which includes radiologists, pathologists, urologists, sometimes IR people, and sometimes engineers on site. And if all happens, you know, like this is a case we did a few months ago, and look at the lesion, anterior, a very high-risk PIRATS 5 lesion with some sort of EP suspicion. AI delineated it very well. This is the immediate post-focal therapy image. We biopsied this gentleman in like a 6 months time frame, and it was tumor negative. So overall, I just showed the work of this team here. And I want to specify some names which we started this journey together. Peter Pinto, Brad Wood, Maria Merino, Peter Choiki, Art Rastinahat, Tom Samford, Srush, Minhaj. These are all valuable people that we all built this together. And I am so happy and honored to present our work over 17 years. And again, if you have any questions, I'll be very happy to answer. Thank you.
Stay there, you're fine. We're going to open up for Q&A before we move to our break, so please feel free to ask any questions if you have any interest in this space. There's a lot of controversy a little bit between approaches. I think the one take-home point is MRI quality is everything. And I'm really impressed that you have an algorithm that checks, because our MR techs at our institution are required to review the MRI before the patient gets off the table. If there's gas on their localizer, the patient gets off the table, goes to the bathroom and tries to pass gas. We used to place a rubber in the rectum to take the gas out, but the techs have asked that that's a little much for them to do. But you have to understand that this entire field is based on risk stratification. And if you don't do a good MRI off the bat, your conclusions, your data, and everything after that is going to be suspect and probably result in a poor performance. Dr. Canfield?
First of all, everything you've always told me about MR quality, I see where you got it from now. I was curious about your predictions. You pointed out that perhaps AI is going to be the best way to find lesions, or currently could be. You pointed out that AI may not be the best way to define region of interest for targeting, for focal therapy, let's say. Dr. Taneja pointed out, using Unfold AI may have some advantages, but he combined that with his own margins. Anyway, what are your comments then about where we are right now and what you see happening for the future for detection and ablation?
I think for detection, we are at a good spot, especially with computer vision assistance. Simply, I showed you a virtual, like moonlighting Turkbey, tool over there. So detection, we are in good place. But burden estimation, we are still not there. So the next step will be taking this registered data and see, the signal pattern in the MR invisible spots based on histology registration, and then further train the model to estimate the tumor burden better. Detection, we are good. Quality evaluation, we are still not there. It is very human dependent, and we are trying to deploy this model into the scanner, so real time it will give the feedback to the tech, because not every technologist is as careful as Arts or ours, So we need to eliminate the human error. Still, there will be expert in the loop that will sign off all of these, but we need to take care of these steps. Thank you.
Yeah, I think the early tools are blunt instruments compared to where we'll be in the future, because as you know, AI is only the data you feed it, right? So you have to have good data in. Of course, how you're modeling it, the question you're asking is really important. So I think all of the tools we have available to us, the fact that they are so early development or early stage and yet perform so well, it's sort of a sign that in the future we're only going to be better, right?
John?
Yeah, question for Samir with regard to the, determining margins and treatment planning. If we look at, radical prostatectomy in intermediate risk prostate cancer, the positive surgical margin rates range between about 6.5% and some series over 30%. And the biochemical recurrence rates at 5 years are about 20%, and at 10 years are about 30%. So my question is, we're starting to see similar results in terms of positive margins, infield and outfield recurrence rates for focal therapy. So just how far we can take this, and shouldn't we be looking a little bit more towards our breast cancer colleagues? Lumpectomy has been around since 1895. It didn't become standard of care, 30 years ago until there was combination therapy with radiation therapy, right? It wasn't about even having breast MRI added to that improved our ability to reduce recurrence rates with lumpectomy. It was the combination therapy. So the question is, how much should we be directing our attention towards combination therapies at this time to reduce both infield and out-of-field recurrence rates?
Yeah, so John, if I got your question right, I think, that's a great idea. Remember, the lumpectomy paradigm is distinct in that they were treating the whole breast. They were just, it was effectively a boost paradigm, right? You're surgically boosting the area of the tumor. I think my radiation oncology colleagues are starting to move there. At NYU, we just bought an MRI LINAC. They have their first protocol for boost of the lesion with reduced dosing of the rest of the gland. So that may be on the horizon. We have a protocol we're talking about doing a focal cryoablation followed by low-dose SBRT to the rest of the gland. But getting back to what we were talking about earlier this morning, I'm not sure that's relevant. If we really believe the focal therapy paradigm, we believe that the risk exists in the index lesion, right? And I think maximizing margin in that location, whether it be a radiation boost to your bed of your ablation or just treating that solely with radiation, might improve the margin, but I think we can do pretty well with modeling. I think the data from your colleague at UCL, Mark, it shows that if you do a lumpectomy and you radiate the whole breast, it's not any different than doing a lumpectomy and cleaning up the lumpectomy margin with focal radiation to that spot. So to me, it's still about margin in the index lesion to create durability and mitigation of metastatic risk.
Yeah, and just to expand on it a little bit, I was thinking along the lines of, you're right there. Do we drop an immunotherapy drug or lutetium or, oncolytic virus? There are a lot of other combination therapy paradigms that are out there. Because one thing we know about cancer is the adjective that describes it best is heterogeneity. And these combination therapies are usually a way to kind of mitigate that heterogeneity. This is just in terms of research and development.
Yeah. Mark?
Two great talks. Thank you very much. And Baris, thanks for mentioning quality again. It is tragic, and it remains tragic just how often we have to repeat MRIs done elsewhere from centers who should know better. And it's a huge cost. It's a great disappointment to the patient and to the healthcare system. One thing we're seeing that doesn't get talked about a lot in terms of MRI quality is angulation. Is that a lot of the prostates they're cut at an angle, and then when you try to reconstruct them, and of course the referring center or the original center didn't spot that, and you tell the patient they've sliced your prostate at an angle, and then of course we have to repeat the MRI. And of course, they've just had a biopsy, so the MRI quality is compromised. But can you say anything about angulation? Because I think that's the big error at present.
Yes, Dr. Emberton, very important comment. Actually, I train radiologists in ACR about every 2 months, and then I have some slides. We call it geometric consistency. So it all starts with the sagittal T2, and then you find the imaginary line between rectum, anterior rectum, and the posterior prostate boundary, and then you draw a line over there, and then perpendicular to that line, you have to image your axials. If you too much angulate, like both ways, definitely you are not helping the patient. And we also ask them to follow, like the same geometric planning for ADC and diffusion and DC MRI. Also, one important thing, never let them use fat suppression. These are big failures, which ends up big cost for the patient. So angulation is very important, and there's a very easy solution for that. Maybe we can build something to plan that automatically in future.
It's interesting because that's a battle at my place. Andy Rosenkrantz, who's at our place, has always felt that the image should be the axial acquisition line should be perpendicular to the rectum. We believe it should be perpendicular to the posterior prostate. So you have sequences where an axial image may show the posterior apex and the anterior, even the anterior bladder neck sometimes. So that's why we always teach to look at both planes at once. Otherwise, you're right, you can be completely lost.
I think we get 2 more questions, 1 minute to go before we have the break. And I think you were first and then Dr. Abreu, right? So please.
Okay. This is a question for Dr. Turkbey, really a request. So the one thing that I struggle with treating focal therapy is how to integrate the MRI and the PSMA PET scan. So I was wondering if you could comment a little bit about how the use of the PSMA PET scan in the delineation of the extent of the disease. And a request from me, after I left your group, I became a community urologist, an employee of Outside Hospital, and my IQ declines by the day. If we could just have a web user interface where we upload the Plarify and get a little delineation of what to do, that would be great. Thank you.
Just one thing, Dr. Sanford worked with us, and he initiated with me the AI program in NCI for prostate imaging, so a big thanks to him.
So I think the question was for you, right?
Me?
About PSMA PET.
PSMA. So PSMA is very valuable, but its main value is, I think, staging at this stage to me. Detection-wise, PSMA has never been challenged without an MRI for finding lesions in the prostate. Readers were always biased that there's already a cancer in this prostate. Let me find that cancer in the gland, and then I can stage the disease. So the data is not very reliable, except for some data from Australia. In estimating the tumor burden, also we observed that there are some mismatches between, PSMA and MRI. MRI being positive and cancer confirmed, but PSMA being negative. I think these are the lesions which drives the biology of these patients. But for burden estimation, I checked last night before coming here. I couldn't see anything convincing.
Okay, thank you. Last question now.
Thank you. Very nice presentation, both excellent, and congratulations for such a great work. One question is, we see some publications when radiologists use computer aid, they have the AI and they use the computer aid, actually their performance go down. Your performance went up 10%. Does it apply only to you or the group, other radiologists as well?
Well, the papers that you see are academic exercises, never like one-on-one challenge, What I mentioned, 10% gap, is a prospective, totally independent of me. I rate the case, sign off, patient decides for a biopsy, we put the images to AI, and the AI-driven lesions, if it is different than what I report, we give at least most 2 lesions to Dr. Pinto and Dr. Guram for biopsy, and that is the 10% difference over there. What you see in literature is mainly, including the PKI study, is an academic exercise, never like prospective, lesion detection attempt by radiologists and AI. Okay.
Last question. Can you make some comment on AI explainability, black box, and deep learning?
Yes.
I think this is a critical field, I think, for medical field, that we use these AI models and nobody explains what happens.
Yes, so you should refrain from black box AI models. You need to, know why this decision is made. Simply, when you consider buying a product, you want to look at the details, right? The properties of it. So what it can do, what it can't do, what it is based on, where it is made, etc. So refrain from black box AIs. Ask for explainability. These are important concepts. Explainability, transparency are important in AI, and we don't see that very often, not only in medical AI, but in everything around us, unfortunately.
So I just want to clarify. Deep learning versus machine learning. And our machine learning is what Dr. Turkbey's system is based on. Pattern recognition, fed-in data. You don't just say what the outcome is, and then deep learning figures out how to identify from the random characteristics that are within that are fed into the system. Is that an easier way to break it down? Because you use machine learning as your primary modality.
Yeah, I think deep learning is a subset category of machine learning, but the classical machine learning, which is not based on deep learning, takes those features, selects the best performing features based on statistics, and then it's basically doing feature engineering. But in deep learning, it is more like neural network architecture has been used to make those decisions. Some people claim you don't need supervision. Some people claim, like me, you need some deep supervision. So regardless of what the approach is, it's giving you an output. But you can get, why this decision is made by using at least salience maps. So I think that is the biggest difference. So, yeah.
Okay, thank you very much. I think we have the break, and tomorrow there will be a artificial intelligence and imaging session in the morning, so I think the talk will be proceeded. Next starts at 9:40, so now the break in the exhibition hall. Thank you.